I want to come back to the plaque and talk about anatomy of the plaque. You've brought up LDL, but we haven't gone deep into this piece. Conventional wisdom would say that's definitely the biggest piece of all this. How do you look at LDL? And then we'll get into other parts of the plaque.
It's a good point. I mentioned LDL on purpose there because I think LDL has been a red herring. If you remember that term, you're familiar with it. It's like, way back in, a couple of hundred years ago, they did autopsies of people dying with heart attack and stroke, and they saw, quote, fat in their arteries. And for hundreds of years, we thought fat was killing us. You eat fat, it deposits in your arteries, it kills you. The science is so different now. And in fact, I get sort of beat up sometimes in the low carb community as a physician because I still do use statins, but I use them entirely differently from what your typical doc does on the street. I don't recommend statin to lower LDL. In fact, I personally don't think that in most cases, LDL is the driver at all. Given what I do, I see enough cases of people that have what we call familial hypercholesterolemia. It's a genetic, are you familiar with it?
I am, yes.
Okay, so there's like 2,000 different genetic variations, which makes your liver struggle in terms of metabolizing LDL. I've got tons of those cases, and over the past couple of years, my number of cases of lean mass hyperresponders has just skyrocketed. I'm seeing nodding your head. You're familiar with that term as well.
Yes, people that are thin and low carb or ketogenic, and they have LDL that's skyrocketed.
Usually, if somebody has an LDL that's 180 or above, they've got an 80 to 90% probability of having one of these two conditions. And Dave Feldman's a friend of mine. I just went to the premiere of his movie, The Cholesterol Code. It's a fantastic movie. They're looking at getting distribution rights through Netflix, I think. And it actually has some of the the follow-up to the Miami Heart Study control group. This group where their LDL wasn't 180, it was on average 272. How does that compare? That's 1 in 1,000 levels. That's 1 in 1,000 people have LDL levels that high. And so you would assume they'd have a lot of plaque, right? No, they've already published the Miami Heart Control Group, where they looked at people from Miami Heart that really didn't have much risk, and these people had the same amount of plaque. In other words, high LDL was not causing their problem. Well, some of these people actually went up to like 700 and above. So we're talking some astronomically high LDL levels. And these people come to me as patients and they say their doctor is just wearing them out, refusing to see them, forcing them to take PCSK9s, multiple drugs. And again, that's why they came to see us, because they've heard us. They know that we know the space. They know that we're not so focused on LDL being a risk. We're more focused on metabolic disease. And I know you know what that means. And I know your audience does too. So we're more focused on your metabolic health than we are on LDL. Back to the original point, we do use statins, but we use them for inflammation. There were a couple of smart guys at Harvard, Gavin Blake and I can't remember the other guy's name. But they noticed about 25 years ago that in comparison groups, people on statins still tended to have lower heart attack rates, no matter where their LDL level was. So that's where they started to think about maybe it's something else, and maybe it's inflammation. And sure enough, over the ensuing 25 years, Paul Rudker, who was the other guy, and Gavin Blake Paul Rutker mostly has done tons of follow-up studies where he looked at different types of anti-inflammatory products and found that some of them had a huge impact on decreasing heart attack and stroke risk. So when we use statins, we use a very, very small amount because you get that anti-inflammatory effect from a low dose. You don't need a high dose. And we're looking at LDL levels. We're not looking at LDL levels. We're looking at potential for inflammation. So at the end of the day, if you've formed plaque, we know that you've gone through that inflammatory stage. You didn't feel it. So we recommend something like a baby aspirin to slow down that clotting process, and a low-dose statin, and only one of two. Rosuvastatin, the generic for the old Crestor, or pitavastatin. And that has to do with things like Lipitor. Lipitor is one of the originals. They were great marketers. Lipitor doesn't really improve inflammation. It does, but not nearly as much, especially if you're diabetic, which most of these folks are. Most of the cases are pre-diabetic or diabetic, or if you're a female. So we don't use Lipitor. We don't recommend it. The other thing that happens is our typical patient will come in and say, well, I've heard you. I know you have a different perspective on it. If you really want me to take it, I can, but I'm nervous. I still have a different perspective, and that is, why do it if you're nervous? Even these low-dose statins are not important compared to lifestyle. If you get those carbs out of these high levels of blood sugar, high levels of insulin out of your daily life, then stuff like statins, any medications have been proven time and again to be way back there in terms of priorities.
All right, there's some nuance here I want to make sure I understand before we move forward. Okay. So it's either the baby aspirin or the statin. And this is somebody that currently has plaque, or what if they had plaque in the past and now they're metabolically healthy and that's calcified? Is that still recommended?
Couple of really good nuanced points. Thank you so much for calling me on those. Number one, no, both aspirin and a low-dose statin. Because the low-dose statin is decreasing the inflammation, cardiovascular inflammation specifically. The baby aspirin is stopping that, giving you a safety net for that next step of forming the clot. So that's what I'd recommend. And again, now to get back to your next point, which is a very good point. Do you know how much data there is out there, how much evidence there is out there about people who are completely cleaned up on their metabolic health, and then a clinical trial for something like a statin or even baby aspirin or anything else?
No idea.
It's just not there. It's just not there. You know, things that we do know, for example, there was a good head-to-head comparison on metformin versus very minimal lifestyle changes for prediabetes. And as you might imagine, even minimal lifestyle changes, like we're talking 5-pound weight loss, we're talking going on a gentle walk a couple of weeks, it was 3 times more effective than metformin. And I think that, you know, given my experience, what I see, I think that's probably a pretty good analogy for statins, for baby aspirin, for all these things. You lose 30 pounds, you're in a whole different risk category than you were before. So that's the focus. It's, again, lifestyle, lifestyle, lifestyle. And yes, the other things like medications, they're, it's like suspenders in a belt. They're helpful, but they're not the priority.
Right. I see where you're going with all this, but I'm curious, somebody who is taking these 2 medications, well, one, is there more natural forms, supplements that can do the same thing? And then secondarily, are they just taking those because they're not willing to make the lifestyle changes?
Well, that gets into our medical culture. I'm a doc. I've spent a career hiring and managing the performance on docs. I understand. I know. I get it. You come out of training before you see your first patients and you think, oh, this is going to work. I know what I'm going to do. I'm going to save the world. I'll just tell people to lose weight and they're going to lose weight. No, they're not. That's not what happens. So the docs just get to a point. Then they start dealing with the hospital administration or the insurance companies, the folks that are watching over them to make sure that they're, quote, productive. Well, what really changes health is somebody's lifestyle, not a medication. So what's really productive is to spend time with the patient, listen to find out what their perceptions are, what the challenges are in terms of lifestyle changes, things like that. But insurance doesn't pay for that. Clinic ownership doesn't pay for that. What do they pay for? Things like prescriptions. So docs just get hammered on both sides of the patient and the payer and the management scenario and just start saying, okay, I give up. I'm going to push pills. And that's what happens. Patients, on the other hand, often, that most people are not going to want to take blame for something. And then they're going to turn around and say, well, my doctor never told me this. All he or she did, they just wrote a script and walked out the door. I think it's a good time to quit blaming each other and just realize the real truth, the real way out of this is not easy, but it's what we got to do.
If you enjoyed that clip, you're going to want to head over here and catch the full episode. I'll see you over there.
I started as an ER doc. I love doing emergency work, but most of these things coming into the ER should have never happened. High levels of glucose or even high levels of insulin irritate that lining of the artery.